Okay, let's talk a little bit about the CPAP. The CPAP was introduced at the basic level, specifically here in Bernalillo County. I want to say about 3 or 4 years ago. This is a great tool for a certain patient demographics. Um, This is a very non-invasive procedure. However, this is definitely a procedure that you are going to have to explain to your patient and really make sure that you get the trust of your patient. Specifically, once again, this is definitely something where we are going to have to. We have a patient that is short of breath. They might be a little anxious. And here we are trying to put this mask, and you can see the mask in this picture, right? It doesn't look very cumbersome, right? And we're going to put this mask over their airway when they're already short of breath, and especially if your patients are claustrophobic, right? Then we're going to really tighten this mask down with this head strap with a whole bunch of headgear to the patient, and then we are still going to have to coach our patient's breathing. However, if we can get past that part, if we can get past the part where we have adequately explained the procedures to our patient, as soon as they take those 2, 3, 4th breaths, they get a very welcoming sensation that their respiratory rate and that their shortness of breath is going to go away. This is an awesome machine. You guys can nebulize medications through this. You guys can also nebulize medications through the BVM. But this is really a machine that has really been a game changer for all of us in EMS, including all the way up to intermediate and paramedic. And it's really saving us from having to actually intubate or drop one of your supraglottic airways into our patient if we are able to get this machine on quick enough. And we do have certain parameters in place for our patient. And we'll talk about that as we go through this lecture. So with CPAP, what this is actually doing is it's increasing that pressure gradient into our lungs. So it's actually forcing that diffusion of oxygen and carbon dioxide. It will open up collapsed alveoli. Think of this as like a security fence that prevents the alveoli from collapsing on themselves. It stents the airway open all the way down to the alveoli level. We can actually push oxygen into the alveoli level, even if they do have fluid in their lungs, right? This machine has something called PEEP, which is positive end expiratory pressure. We'll talk about that here in a minute. And it kind of forces the lungs open. So we are technically kind of hyperinflating the chest of our patients, but because we are doing that through this machine, we are able to get that adequate gas exchange, which eventually is going to calm our patient down, which is going to start stimulating our chemoreceptors in our brain, and we can actually lower the respiratory rate of our patient. Technically, CPAP is a vent, guys. It is a very subtle setting, I guess is the best way to put it, that even all vents have, the automatic transportation ventilators. This is an awesome machine. I don't want you guys to fear it. You guys, it's very loud. It's hard to hear the patient. It's definitely hard to hear the patient talk. So we want to make sure that we're getting a good sample history, trying to get as many questions as we can out of our patient before we put this machine on. But if we can't do it and we need to throw this machine on right away, let's do that. We can ask questions later, right? Because really when it comes down to it, it's all about airway breathing and circulation. And there's going to be times in your guys' EMS careers where you guys are focusing on nothing but the airway the whole time you are with the patients. You're going to get to the hospital and you have no vital signs for the staff, and that is okay. You have maintained the airway. Okay, and every emergency physician understands that, right? That sometimes some patients are difficult and we can't get past A for airway, all right? But this will actually push fluid out of our way in order to recruit alveoli, and once we actually get that fluid out of the way, like I said, those alveoli are stent open for proper adequate respiration or gas exchange at the alveoli level. Okay, so this mechanism, still we are delivering this through a face mask that's actually held to the face through a strap system. And it's basically a strap system that kind of covers the top of the head and kind of comes around the bottom side of the neck. And the actual straps attach right directly to the mask. We do need to be very cautious with people with low blood pressure. So again, your normal range for blood pressure for the systolic, the top number, is anywhere between 90 and 140 millimeters of mercury. The diastolic, which is the bottom number, is anywhere for normal, anywhere between 60 to 90. So borderline high blood pressure is 140 over 90. Once we kind of start moving towards the lower side, we want to be careful about using this with patients with low blood pressure. And the reason why that is because the patient has a low blood pressure, we are increasing the intrathoracic pressure, just like we are with the BVM, which means that we are technically hyperinflating the lungs of our patients because the lungs are hyperinflated or stent open, however you guys want to put it, with the CPAP. Those lungs are technically somewhat pushing on that vena cava, the superior inferior vena cava, which is slowing down the actual blood flow back to the heart, which if we do it with, if we have somebody with low blood pressure, we put them on CPAP, we can actually crash them, okay? If we're doing CPAP and they do have that low blood pressure, we can actually drop their pressure so much that they go unresponsive on us, at which point we can no longer use the CPAP. We have to have some kind of, the patient has to have some kind of respiratory drive themselves in order to use CPAP in the first place. Okay, so when should we think about using this? We need to make sure that our patient is alert and able to follow simple commands, okay? That they're alert to person, place, time, and events, and that they're able to follow simple commands as like sit and stand, and just kind of be able to do the things that you're asking them to do, okay? If your patient is displaying obvious signs of moderate to severe respiratory distress, they're breathing too fast, they're breathing too shallow, they're breathing too deep, their skin color is very pale, they are showing signs of cyanosis, their blood pressure is still within normal range, right? We are your pulse oximetry reading is very low, and I'm talking really like maybe possibly in the low 80s, high 70s, or even lower than that. Patients breathing too rapidly, or your pulse ox is less than 90%. I'd be careful with that. I would want to see that. Me personally, I don't think about CPAP as a paramedic until I see that oxygen saturation probably below 85%. And again, you guys can put the CPAP on in order to stabilize your patient. Once they become stabilized and you guys are comfortable with it, you guys are seeing good improvements, that point you guys can think about maybe taking them off the CPAP and putting them on like a non-rebreather to maintain the patient. But it's really going to be based all upon patient presentation, and you guys will definitely get more training on the CPAP when you guys get into your services. Contraindications for CPAP. Your patient is in respiratory arrest. They do not have their own respiratory drive. Okay, you can't do that with this machine. Okay, this is a point where we need to whip out the BVM and start breathing for our patients. Any signs and symptoms really of any sort of chest trauma, stabbings, significant bruising to the chest wall, right? Symptoms of a pneumothorax. You might not be able to hear lung movements in one air. The last thing we want to do with that is increase the pressure of a lung that's blown, because we're really doing some serious squeezing inside of our inner thoracic cavity. We're really increasing that pressure way too much. We just don't want to use it with trauma patients, specifically trauma patients that are showing signs and symptoms of chest trauma. Patients who have a tracheotomy, we can't use it with that. We can't hook them up to the CPAP, and we can't cover their tracheotomy with the mask. In fact, there's no possible way of doing that. We would have to actually hook up the BVM to the tracheotomy because they are universal and help the patient breathe that way. Anybody that has any active GI bleeding or vomiting, specifically, even if they are saying or complaints of nausea at the basic level. Now, that's going to change when you move up, because when you guys get to intermediate, you guys will be able to give medications to help patients with their nausea. And you guys will be trained to give those medications prophylactically before you actually put them on a CPAP. But for now, at the basic level, you guys cannot hook up the CPAP for anybody with even the complaints of nausea, okay? And then patients who are unable to follow verbal commands, right? They have to be somewhat awake. They have to be able to follow some simple commands in order for you to get this machine to be able to set them up and explain to them the process, and then kind of coach them on how to breathe with this in order for them to be able to oxygenate appropriately, in order for you to see the actual benefits of the machine. And guys, this isn't a machine that, yes, it can hurt you, but it is a very non-invasive machine. And if you guys ever get the chance with your services to actually put one of these on, do it. And take some nice deep breaths in, okay? I guarantee they will be the best breaths you have ever taken in your life. And you guys will actually feel what it can be like. And I guarantee if you guys put this on your face and you hold it tight to your face and you breathe in a good 10 breaths, you will feel what it's like to be over-oxygenated. You will actually start to possibly get dizzy, right? This is a very effective machine at getting good, adequate gas exchange for anybody. So what exactly does this machine do? Basically, what this machine do is it creates a resistance in the airway for our patients. It stents the airway open. We are technically somewhat hyperinflating the lungs. We are using PEEP, that positive end expiratory pressure, in order to do this. We're going to talk about PEEP more specifically when we get to respiratory emergencies. But it basically creates a back pressure, and that back pressure is what kind of stents open our alveoli in order for good, adequate gas exchange. So that back pressure actually pushes open that smaller airway, those really kind of smaller microscopic airways, wide open as the patient exhales, okay, in order to prepare for inhalation again. But because that back pressure is created during the exhalation process, during the PEEP process, when we take that next deep breath in, our lungs are already situated and prepared for that adequate respiration or gas exchange. When we're talking about PEEP, your PEEP is actually anywhere between 5.0 to 10 centimeters of water, okay? You guys at the basic level can go no more than 10 centimeters of water on your PEEP, and it is actually a valve that you can twist in order to provide more back pressure. That's all PEEP is back pressure, giving more resistance to the airway, okay? When you guys move up in level of licensure, you guys will be able to play with a little bit more PEEP. The problem with actually inducing more PEEP in our patients is that it can get them extremely dehydrated. So the reason why we stop you guys at 10, which is about the average, right? Most of the time, even myself as a paramedic, I'm not going past 10. There has been a couple instances where I've gone up to 20, but those were very sick people. But we usually stop right at 10, and we stop you guys at 10 because you guys are not able to start IVs. You guys have no way at the basic level at this time, you guys have no way at the basic level to actually do fluid replenishment for your patients. That is changing, guys, okay? To be honest with you, I can see in the next maybe 5-10 years, we are going to be teaching you guys at the basic level on how to start IVs. So again, we are trying to get you guys to become good, adequate technicians so that we can advocate for you guys at the higher levels in order for you guys to do more stuff for your patients. CPAP, some patients do find it kind of claustrophobic. And again, this is all going to kind of come down to your therapeutic communications with your patient, right? Letting them know that you're there. You're there to help them. You are there to cause no further harm. You are trying to fix their shortness of breath. You are trying to get them to do adequate gas exchange, and that until they kind of realize and take those first few breaths in, for lack of a better terms, this is going to really suck for our patients, specifically when we are setting this up. So we have to have that good therapeutic communication. We have to build that trust with our patient, and we have to talk to them. We have to talk to them. Okay, they need to realize that this machine that I'm going to strap and hold down to your face, even forcefully if I have to, as soon as you start breathing in, it's going to help you out. And I think the best way to do this is try to get the patient involved as much as possible. When you guys are holding that mask to the face, have the patient do it themselves. Have the patient do it themselves while you guys are setting up that headset, right? In order to strap it down to their face. Turn the machine on while you are doing this. Okay, crank that machine on, right, and turn it up to start at 5 of PEEP and have the patient hold it forcefully against their own face and have them start breathing while you are setting up the actual headset for it. It's amazing how putting somebody in charge of their own treatments can really be beneficial. And I do have a story for you guys, specifically when we get into respiratory emergencies, on just that, on how I put my patients to work. And there's nothing wrong with that, guys. Okay? Your patients have 2 hands. Understand that. Your patients have 2 hands. We're going to talk about it in trauma. We're going to talk about it in respiratory emergencies. Let's put them to work if they are able to work. Okay? We'll talk about that later. If the patient does start showing signs of deterioration, if the patient's respiratory drive is starting to lower, if they look like they're getting more pale, if we're seeing drops in pulse ox, if we're seeing rises in end tidal, if they are just starting to get tired, more than likely we will have to remove this from them and start to bag our patients. Here's the other good news, is most of the time the actual mask that you're using for the CPAP is interchangeable with the BVM. So if you guys see your patient deteriorating and you already have this mask hooked up to their face and it's strapped down, guys, just remove the CPAP machine, leave the mask to their face, hook up the BVM, and start bagging. You have a way of holding a seal because you have already created that seal with the CPAP mask, right? This is just kind of tricks of the trade, guys, okay? Work smarter, not harder. Okay, some patients with some special considerations. We do have people that are on tracheotomy tubes. The picture there is actually of a stoma. This is somebody that has had the tracheotomy tube pulled out of them. Again, remember that the tracheotomy tubes can be permanent or they could be temporary, all right, depending on the patient's condition or what happened to the patient. Guys, this is where they are breathing out of, okay? So if your patient's complaining of shortness of breath and they have a tracheotomy and you guys put them on a non-rebreather over their mouth and nose, you are not accomplishing anything, okay? You guys can actually put a non-rebreather right over that, okay? You guys could just hold it there if you need to, all right? That is the patient's airway, okay? They have completely bypassed their nasal and oral pharynx. That is a direct line right into the trachea. It is the easiest airway for you guys to manage. However, every now and then you guys might need to suction that out. And I'll tell you, suctioning out a trachea is not the most pleasant thing in the world. Again, they are not able to necessarily filter the air that they're breathing in appropriately. So you can get some really nasty, smelly phlegm out of these bad boys. And I'm talking like slime. I'm talking like where you can start suctioning, and you go to pull that suction Yankee hour device out of there, and all this phlegm is just kind of stringing out with you. Okay. You guys will get training on how to do a tracheotomy depending on what service, how to suction a tracheotomy depending on which service that you guys are going to. Not all basics are allowed to do it. It is service dependent. It is a special skill. But most of the time, this is really a job for your paramedic. But you guys will get training on this when you guys get into your services. Again, guys, this is a direct line to the patient's airway. This is a hole in their trachea, right? This is probably the most secure airway that you can have as a person, right? A hole drilled right into the trachea. Very little air movement is needed in order to get that air down into the lungs, okay? So that being said, remember that this is the patient's airway. The head tilt chin lift or jaw thrust maneuver is not going to work because we bypassed the nasal pharynx and the oral pharynx, okay? If the patient does have a tracheotomy tube in place, yes, you guys can put over the non-rebreather mask. You guys can go back and read on some of the slides that I skipped over. There's something called the Venturi mask. None of the services carry it, but some of the hospitals do. It is actually a non-rebreather mask that is made for a tracheotomy tube. It sits right over it in order for the patient to breathe. And the best thing in medicine, you guys are going to learn this real quick when you get out there, is obviously not everything is universal, okay? But what they did do right in medicine is that the tracheotomy tube is universal. The actual connection is universal with your BVM mask. So all you have to do is hook up your BVM to the tracheotomy and squeeze when the patient's breathing. And this is the best time, guys, to put the patient to work, right? Especially if this patient's at home with a tracheotomy and they're on a vent, and for whatever reason they need to go to the hospital, right? And they're awake and they're alert, right? And they're looking at you. Some of these patients might not be able to talk, okay? But just because they're not able to talk doesn't mean they're stupid, all right? Give them the bag. Hook up the bag and have them squeeze and tell them, listen, dude, I want you to squeeze this bag every single time that you need to take a deep breath in. Put the patient to work. There's nothing wrong with that. Another little trick of the trade for you guys, if the patient does just have a stoma and they do not have the trach tube actually in place for you guys to actually connect the BVM directly to it, drop down your size that you would normally do for the mask of your BVM for your patient. We have about 6 or 7 different sizes of actual BVM masks that we can hook up to the BVM, and it goes all the way up from neonates to adults, and I would drop it down to even a neonate, right? We just want to make sure that that mask is actually covering the whole of the stoma and making sure that we're actually getting a good seal if we do have to ventilate our patient that has a stoma without a trachea tube in place.